let's go over and see if we can connect with that difficulty swallowing. So, in my mind right now, I'm feeling something. I'm feeling a piece of frozen chicken, some density, some tightness, a grumpy area, but I put less weight into what I feel, and all I do is simply put a little bit of stretch. And Melissa, what are you feeling?
I definitely felt a little kind of knot, I guess,
A
on the
knot.
left side.
Yeah. Is that familiar to you?
Mm-hmm.
Is that part of that swallowing issue?
Yeah.
Good. Does it feel safe?
Mm-hmm.
Yeah. 0 to 10, how much pressure am I using?
5.
A 5. All right. What number would you stop me at?
Probably a 7 or
A 7.
8. Mm-hmm.
Would you prefer that I backed away from a 5, or does a 5 feel safe?
This feels safe.
Okay, it feels safe, but does it feel like it's doing something? Does it feel like it might be a helpful stretch?
Yes.
Is there anything about this stretch that feels like it might be harmful to you?
No.
Okay, so she established that it's familiar, it's relevant. She said the pressures, a 5 is a little higher than I might want to go, but she said it feels very safe. She'd stop me at a 7 or 8. It feels like it might be helpful, but not harmful. Does it feel like it might help with that swallowing issue?
Mm-hmm.
Good. That's what I wanted it to tell me. Some patients don't always know if the stretch will feel helpful. They leave it up to us. All right, I'm willing to accept that, but I want to make sure there's nothing about what I'm doing that feels like it might be harmful or hurtful if it does.
Hi, this is Walt Fritz from Foundations and Manual Therapy Seminars. Thanks for joining me here today for my talk on shared decision making in manual therapy. I think it's about letting go of control. What is control? Control is our education. Control could be the results of that education, the results of that training, the results of our experience, the results of our patients having positive experience from our manual therapy, our massage work, our myofascial release work, whatever you want to call it. This is a controversial subject in a lot of ways, but I want to sort of unpack it today and give you some ideas how it can work, why it works, and how you can apply it. First of all, a little bit about me. I'm a physical therapist from New York State. I've been in the manual therapy field since the early 1990s. First emerging in a myofascial release model where I learned all about fascia, I learned all about what's wrong with it, I learned all about how we can impact it, or how it was said we can basically identify it in the body, identify fascial restrictions, and treat it. I worked with that model. I started working for a well-known educator in the continuing ed field of myofascial release for about 10 years. And then after a while, branched off on my own, teaching my own form of myofascial release. Initially, it was quite like how I was taught. And then over time, I began to sort of get my own voice in that world. So much so that I started to question what was going on in that myofascial release world, what was going on in fascia, and what was going on in all the manual therapies. One thing that struck me early on was when you go on social media and you, for instance, if you join a group on myofascial release, join a group on craniopsychotherapy, join a group on neuromuscular therapy, join a group on all the dozens or maybe hundreds of modalities and intervention styles we can learn, you start to read through the posts and you start to read how, basically everybody's getting phenomenal results from their work, which is lovely. I mean, that's why we take these continuing ed classes. That's why we train in this work. But something struck me that why is it that they all got good results? That's something that isn't really talked about much. I mean, I know in my myofascial release training, it was really about almost putting down other interventions as not quite good enough, as missing the secret, missing the important stuff, that it was only us trained myofascial release therapists who really could identify and treat and really heal people. And I bought into that for a long time. It was kind of ego boosting stuff to think that you are holding the key to the kingdom and are really the one with the answers. But the more I started to look at all the other models and listen to them and read them and watch them, it's like, wow, you know what? We all help people. And I don't know of a study that truly shows one style of manual therapy, one style of massage, one style of any kind of intervention is truly superior than another. There was a recent study done in the physical therapy world that showed that despite common preferences and biases today, that basically exercise, manual therapy, and patient education all have approximately equal outcomes. And to me, that should be really kind of troubling to some people who claim that they've got the most effective intervention out there. So what happened over the years is I really started to step back from the words myofascial release, the thought that I can intervene specifically on the fascia. And it wasn't until COVID, when nobody had anything to do with it, I decided to rebrand my work, rebrand what I do here in my office in upstate New York, as well as what I teach to folks like you. And I just call it manual therapy. I thought it represented a more honest representation of the work that I teach, the work that I use, and how I explain this work. Because no matter how much somebody insists that they can detect, isolate, and treat specifically and with full specificity on an individual muscle, on an individual layer of fascia, even on an individual nerve or joint, that we cannot exclude the wholeness of the human being and all of those potential confounders that happen when we touch somebody, the confounders that could in and of themselves be part of why a person improves. When I touch somebody, I thought I was reaching in and feeling and treating their fascia restriction. But then I watched somebody from across the room doing a different form of manual therapy or massage, and they're doing remarkably similar things with their hands, but yet they feel they're impacting on a muscle or a nerve or sometimes a joint, sometimes an organ. Shouldn't that be troubling? Shouldn't it be something that we question? How is it that we can reach through this big thick skin suit and think that we're selecting all these separate tissues, when in fact all we're touching is the human being? So in that brief introductory video that I showed, it gave you an idea how I might work with a patient, how I might treat a patient, how I might interact with a patient, and importantly, how I may require my patient to be an active participant in the entire process. Our work, I'm going to include myself in with the world of massage therapists, because I think there's a tremendous amount of overlap between all of our professions. That overlap extends from our training and in some cases our education, although there's some differences in Canada and the United States with the massage therapy education as well as physiotherapy education. But I look a lot at what happens when we get out of school and we're exposed to continuing education, where hierarchical type models are pretty common in our shared fields. Models where we take an introductory continuing ed class in a modality or some similar kind of training, and after that introduction we're sort of like drawn deeper into a rabbit hole of that training. Something about that model resonates with us, and we decide that's what we would like to do. Maybe not as what you do in its entirety, which is what I did with myofascial release, but you like to include the principles of that in your general framework of how you teach. So, the more classes we take, the more we learn, the more experience we gain from applying that model and then going back to a continuing ed seminar, and we get additional training, additional techniques, and additional pieces of the narrative that kind of seduce us, I think. And I know that sounds very cynical, but I've become very cynical when I look back at a lot of my education, my training, my continuing education training, and myofascial release especially. So much so that it kind of, at least in my case, it created the sense that I knew things that others didn't. I knew things that other clinicians didn't. I knew things that other physicians, or the physicians who referred to me, didn't know, because they didn't know about the fascia. They weren't trained about the fascia, not just the anatomy and the physiology of the fascia, but the way to access it, the way to properly access it, according to my original continuing education model. And it became a place where I was sort of embedded in my ego. And sure, I don't know everything, but I knew a lot. And I knew a lot about fascia, and I knew a lot about fascial problems that when a patient came in to see me for treatment, I told him about, I taught him about, and then I treated it. In its very simplest form, the post hoc fallacy is exemplified by a rooster crows every morning, followed by the sun coming up. And the post hoc fallacy would say that the rooster caused the sun to come up. Now, of course, that's kind of absurd, but yet a lot of what I was taught in manual therapy training, and in school for that matter, was that, here's all of this information on a tissue. Here's all this information on the dysfunction of a tissue. And it doesn't matter whether it's a fascial tissue or a muscle tissue or a joint, etc. But here's all this information that I was given, that we're given on a problem. And then we're taught intervention models to remediate that. In my world, it was here's fascial science, here's fascial evidence, here's fascial things that other people don't know. And then we were taught how to treat that fascial problem. And our patient got better. And that's kind of hard then, unless you have extremely good critical thinking skills in the setting of a continuing ed seminar, to really ask those tough questions like, is that evidence that you've been given actually correct? I lacked those completely when I was taking my myofascial release training. I lacked the ability to really apply a filter of critical thinking to what I was taught. And it was basically, wow, they taught me about fascia. It helps people get better when we do this work, so it must have been a fascial restriction at cause. Now, I'm hoping that I'm in a minority of folks who allow that to be what guides their intervention. But from what I read on social media, it's not the case. When you go into some of these rabbit hole groups on Facebook, the hundreds of them for all the individual lines of education, people teaching the work, et cetera, et cetera. People pretty much believe that it was because the pelvis was rotated, it was because they had a subluxation in their spine, it was because they were weak, it was because their fascia was restricted, et cetera, et cetera. And you know what, for the majority of what you and I do, you might say, well, what does it matter, right? We help people get better. And I agree 100% with that. And I don't ever try to get in the way of another person's decision-making process because I've not lived their life, just I've not lived the life of my patients. But I do recognize that there may be, in addition to all of those tissue-based stories that you and I were taught, maybe there's common denominators that are going on when we treat a person. The common denominators being not just their fascia or their muscle or their joint or their nerve. The common denominator might be the relationship that we build with our patient. The Therapeutic Alliance, it's called. Therapeutic Alliance was introduced. It kind of goes back a long way. One of my favorite papers is a paper by Carl Rogers, psychologist Carl Rogers, back in 1957, where he introduced a paper at a conference back then that basically got him blackballed from the psychotherapy profession, or at least vilified for a lot, because what Carl introduced in that paper was the concept that it wasn't the modality that was truly making the effect. And I guess back then, and maybe even now, modalities are key in a lot of psychotherapeutic interventions, where it was viewed that a specific modality, a specific way of using psychotherapy with a patient is more effective than another. And what Carl Rogers was basically saying was the modality doesn't matter. It's the relationship that we build with our client, with our patient, that truly is the impactor in that whole relationship when somebody does improve from psychotherapy. And you can see how that could rattle some cages in the psychotherapy world, especially back then when a lot of these new models were emerging and they're all viewed as being groundbreaking. And it probably sounds kind of familiar to our world over the last 20 years, last 30 years in my manual therapy experience, where each one of these models comes forward and they're saying, no, this is the key to the kingdom. This is the answer. This is how you will help patients. And it doesn't matter whether it's manual therapy or exercise or education or pain science or anything. It's like everyone seems to have the answer. Well, it's like, well, maybe we all have the answer. And maybe the answer is in the relationship that we build with our patient. This relationship that we build with our patient is an interesting one, I think, as an observer, because that tiered model of continuing education, or education that most of us have received, essentially elevates us to the role of the expert, the role of the clinician as expert, which is basically the norm I think the norm in manual therapy. I think it's the norm in medicine. I think it's the norm in physical therapy and massage therapy in general, where a person, a patient, a human being in need comes to see us for our expertise, per whatever problem or condition they're dealing with. And in a lot of ways, most of them hand over to us trust and faith that we know what to do, or we can help them figure out what to do. And it's sort of, that's the norm. They come to us saying, I've got this pain in my neck that I just can't get rid of. What do you think it is? And then we go into evaluation mode, and we look around, we check things out, and we come up with a conclusion. And the conclusion, interestingly enough, is typically framed from the modality of our heritage in terms of what we learned. I'm going to give you an example. When a patient came to me when I was steeped deeply in the myofascial release world, a problem was typically framed from fascial perspectives. And if you're a muscle-based clinician, it's a muscle-based perspective. Trigger point clinician, you're going to explain that problem based on trigger point understanding anatomy and physiology and beliefs, etc. And all of those, the models seem to work, but they trust us. We give them this information, and even if they don't understand us, they might kind of give us a blank stare where that they don't really know what we're talking about or understand the language we're using, and then we go into an explanation that they kind of nod their head a lot. It's like, okay, it's a good story, that fascial story. It's a good story, but let's get to work. Can you help me? And then we go and apply that work, and a lot of the times it really does help. I mean, let's face it, that's how I worked for years, and I had really good success using the fascial narrative. But the weird part is you're using a massage narrative that could be based on muscle stories, et cetera, et cetera. What is it about that whole process that is helping? The clinician as expert model is one that it's hard to get people to move away from. It's hard to get clinicians to move away from, and it's hard to get patients to move away from, because you know what? I am an expert. I've taken a lot of training. I've got 30 plus years of experience in this manual therapy field, and a lot of it in education to folks like you. But no matter how much I know, no matter how much I've learned, no matter how much of experience I've had, etc., there's one key piece missing from that, and that's your feelings, your values, your expectations, what you're seeking for, what you're searching for. And that's what I've been doing over the last 10 years, is evolving my model from me as the expert and allowing it to move on into maybe us as experts, or even my patient as an expert. Because let's face it, the patient is an expert in their lived experience, in their body experience, in what's happened in the past with their priors, what's going on in the present, as well as their hopes for the future. Shared decision making is about equalizing power. It's about taking the elevated position as clinician, as expert, and trying to bring it down to a level that's relatively equal with the experiences and the values and the opinions of the patient. Which is a tough one for a lot of patients, because a lot of patients will say to me, I don't know what's going on. You're the expert, you tell me. I mean, they may not say it exactly in those words, but that's the kind of message we get from a lot of people. Like, I came to you for your expertise. Why are you asking me all these questions? Well, I'm asking you these questions because, I can explain this to a patient where I literally will tell them about all these different stories that I've learned, which makes me wonder which story is the right one, or maybe it's all the stories combined. And I think if we can add your story in here, we might build an even stronger relationship, and that relationship could be pivotal in improving outcomes. In the notes from this class that I'm teaching here, I'm going to include a fair number of research references for those of you who are interested in following some of the breadcrumbs of the topics and the concepts that I'm talking about here with shared decision making, therapeutic alliance, etc. And the shared decision making, if you're trying to go into the evidence and say, does it improve outcomes? Well, there's some papers that are starting to show that yes, it does. There's some papers that definitely show it does. I include the concept of therapeutic alliance in with shared decision making because truly they overlap and mesh together perfectly. And therapeutic alliance has a fairly robust level of evidence showing that therapeutic alliance is a huge part of why is it that patients get better, that improve when we build a strong relationship? Some of this should be obvious. If you and a patient are just not hitting it off, they tend to stop coming. We tend not to help them. Ones that really seem well aligned with us, both as a person as well as a professional, we tend to help them more. Now, I know a lot of people, when it comes to their background, their education, and the skills they've learned, when someone starts telling them that part of the outcomes, or a good part of the outcomes that they're achieving, might not be due to the thing that we think we're doing to the tissue, but the fact that we're relating to that person in a way that is compatible with that person's values and expectation, that tends to get people a little grumpy, because it goes against that concept of, what do you mean it's not that trigger point that I'm fixing, or that fascia restriction that I'm releasing, et cetera, et cetera. But in that evidence for therapeutic alliance, there is a lot of evidence to show that contextual factors, the fact that we're building this strong alliance, going back to Carl Rogers' principle in a lovely paper by Misiak in 2018 that talks about, in the physiotherapy profession, how therapeutic alliance can elevate outcomes. And those are the type of things I'm talking about here with shared decision making. It's not to discount what's happening at the periphery, in the tissues, in the patient's body, but to see that as the only reason a person's getting better, I think, is missing the last 50 years of the advancement of science and medicine, and our therapeutic knowledge as well, that there's so much more to a clinical interaction beyond what we think is wrong with them and beyond what we think they're doing to the tissues. There's a paper that might seem a little bit outside of the realm for the massage therapist, manual therapist, but in my work I teach speech pathologists, speech therapists, a lot of work for voice and swallowing disorders, and it's become kind of my interest over the past 5 years that I've sort of focused on. But there was a paper done in 2017 by a lead researcher by the last name of Nelson Roy, and for in the speech pathology profession, back in the early 90s, when laryngeal manipulation was first introduced for a problem with too much muscle tension in the laryngeal region. It's called muscle tension dysphonia. It's originally thought as too much muscle tension in the perilaryngeal musculature, the inferior constrictors of the larynx. And it was seen that when we go in and we manipulate that larynx, that the patient's voice improves. So initially back in the early 90s, they saw it as a local problem of too much muscle tension and a local solution of manipulating the larynx to bring down the muscle tension. It's a parallel explanation for a lot of our worlds of muscle and tone and trigger point and fascia, etc. But what I really admire about Nelson Roy and following his research from 1993 to the present is how he started off with that. It's all about too much tension here, and we manipulate and it gets all better. And then you read his research going through the 1990s, the 2000s, and 2010s, and he basically went from what happens in Vegas stays in Vegas into the 2000s, where he started talking about a cascade of influences, not just that it's not only local tension that's creating that, it's top-down effects, psychosocial, behavioral, psychological impactors that may be impacting the muscle tension, as well as potentially injury, overuse, etc. But not only was causation, in a sense, being viewed from a more blended perspective, that it's about the person and not just something wrong with their muscles, but our intervention was being seen as having a cascade of effects from peripheral to central and central back down to the periphery. But then in 2017, Nelson Roy introduced a paper that was called The Neural Bases of Muscle Tension Dysphonia. And again, while it might seem a little out of the lane of the manual therapists and massage therapists, I see it as completely relevant. Because what they did in this paper was they had a patient, it was a case study, they had a patient with muscle tension dysphonia read a script. They used a script so that it was a predictive way that they could compare before and after. They had the patient read the script, but they had her read it while she was in an MRI. And what they were watching when she read the scripts was what part of her brain was in essence active. And what they noticed is this, in this woman with muscle tension dysphonia, a lot of abnormal centers of the brain were active and inactive, way different from what they would expect somebody to do with a normal voice pattern, a normal muscle tension pattern. And then what they did was they pulled her out of the MRI and they did the equivalent of about an hour's worth of intervention. And in that model, it was laryngeal manipulation, laryngeal reposturing. Again, a lot of this is exactly what you and I do throughout the body, head to toe, low back pain, neck pain, foot pain, etc. They did their laryngeal manipulation and reposturing, and then what they did is they bring that larynx down, and then they start having the person begin to talk to see if they can create a more normal voice with less hoarseness, with less raspiness. Much like getting a patient to move with less pain and less fear, with our hands in place, can that person begin to feel safer and more effective in terms of what they're trying to do, or less dysfunctional. And then what they do is they taper the pressures away until the patient can hold some or all of those gains. Well, that's what they did with this woman. And then they slid her back in the MRI machine and they had her read from that same script again. And what they saw was almost a completely different brain pattern. That the brain activation centers normalized. They went to the areas of the brain that would normally be active during speech. And what they saw was that that hour's worth of intervention created a massive change in what was going on in her brain. Now that study does not show that the problem was in the brain and not the tissues. It doesn't show that at all. But to me, what it shows is that the problem is in the human being. That maybe possibly we were just working down here with the tissues as the signaler to higher centers, instead of that being the impact, right? So what does that study and a number of studies like them have to do with shared decision making? Because basically it was still the clinician in that research study. The clinician was applying their expertise. It's not a perfect example of shared decision making in action, but to me it's a perfect example of why we should begin to question those peripheral tissue-based narratives as the explanation for everything and start to look at the whole person. Well, when we move into the evidence for shared decision making, I think that you will begin to see some relevance to, first of all, that study and hopefully what I'm talking about here with Therapeutic Alliance, as well as the importance of elevating your patient from a role as basically allowing you, the clinician, to be the expert, into one where we look for a relatively equal power sharing. Now, in any relationship, be it a personal relationship, romantic relationship, or professional relationship, it's never equal all the time. The power that we have in any relationship is constantly ebbing and flowing. But I think for a healthy relationship, that on average, we should be at relatively equal roles so that each person can feel fulfilled and happy and that they have a voice and they're participating with their partner's voice, right? And I don't see that this should be so much different in the therapeutic relationship either. You know, in the United States, a physical therapist is required to work from an evidence-based model. An evidence-based model is one that has essentially three separate components. One is the research that we use to support our work, that we use to give it a foundational explanation for the mechanism of actions, not just the outcomes that we use, but how things work. Second part of that evidence-based model is the clinician's experience applying that evidence, and that's where we get a little bit of latitude with the evidence, because there's evidence for a lot of different types of models working, but how do we apply those in the real-world setting with our patients? The third piece of that Venn diagram, if you will, is patient expectations and values. And you know, the way the model was set up originally, it was three equal circles, somewhat overlapping. Three equal circles of the evidence, the clinician's experience applying the evidence, and patient values and expectations. And I think when I observe clinicians working, and it doesn't matter whether it's an exercise-based model, an educational-based model, or a manual therapy-based model, I really see, you know, these two as coming in strong, especially clinician experience. Hopefully it's applying that evidence. A lot of times it's applying the evidence that we were taught from the rabbit hole of our training, but either way, there is evidence to support that. But what about the patient's values and expectations? How are you meeting those? How am I meeting those? looking back on myself in those many years as a myofascial release therapist, a lot of my model was about that evidence and my experience and basically convincing, maybe not convincing them because I think that's a pejorative word, but educating them on their fascia, educating them on what could be wrong. And I realized I wasn't giving them a huge role in the therapeutic environment that was going on. They basically took my word as the expert that, okay, let's give this a try. That's why I'm paying you. That's why I'm trusting you. Let's do it. But how was I building that patient expectations and values into a full third of my model? And I'm realizing now that I really did a pretty poor job of that. In some cases, we do things like ask them how the pressure is. Well, the pressure's fine. I can take it, right? We hear things like that all the time. Well, it's lovely that you can take it, but must you take it? Do you need to take it? Do you want to take it? Do you have an opinion on a pressure that could be different from what I'm using? Do you have an opinion if what I'm doing right now feels like it might be helpful? Those questions like that are really weird questions to ask in our world because we're supposed to know what to do. We're supposed to know how hard to push and what style of pushing to do, et cetera, et cetera. But the way I'm viewing shared decision making in a manual therapy model is one where, okay, we're going to come in with our opinions, with our experience, with our training, et cetera, but we're going to maybe bring it down a notch or two, and bring their opinion up a notch or two. I want to play a video right now that shows, it's a video I made a couple years ago that shows me and my model, a pretend patient, working on an issue in the ribs that she, pretend to come in with. And, I look back at that video now because it's been probably 5 or 6 years since I filmed that video, and I've changed in terms of my language that I use with my patients, the way I phrase things, what I request and almost demand of them, but yet it still remains pretty relevant to this model of elevating to the patient into an equal stakeholder in the therapeutic relationship. And, this is, to me, shared decision making in action.
Okay, what I want to do now is give just sort of a brief overview of my approach to what you might consider a neurological-based myofascial release or manual therapy type of evaluation and treatment session. Now, Melissa came into me with symptoms in this aspect of her rib cage. She related to me that it's ever since the birth of her second child, when she is laying down and goes to sit up, or all sorts of various activities that involve engagement of the abdominals, she gets a cramping in this area that was new since the birth of her second child. So she came in to see me to see if we can do something about that. So my old myofascial release training taught me to say things like, well, there's a fascial restriction in this area that needs releasing. But the next therapist might say, well, you've got a muscle spasm that we need to release, or a trigger point that needs to be worked out, or dozens of other stories that we tell people about what we think the problem is. Ultimately, I'll never know for certain what it is that's wrong with her, what happened, or what it is that changed with her if I successfully help her. Looking at this from more of a neurological model, we could take a look at some of the cutaneous nerves that we have the potential to impact through neurodynamic technique. It could be using the mechanoreceptors embedded in the skin that provide stimulus up to the brain, and the brain then provides a descending modulation to allow change. It could be totally indirect effect where I'm paying attention to her in a place where she feels a good feeling. It could be fascial change, it could be trigger points, it could be muscle spasm, it could be dozens of other things that we're taught and we continue to tell patients. But ultimately, I'll never know for certain. This neurological model that I use, there's a lot of uncertainty in it, in that people aren't sure exactly what's happening. But what I'm going to do is go through this with Melissa for a few minutes, and we're going to talk about the process while we're going along. So, Melissa, you related to me when you feel that area. You pointed to the area of your body. What I want to do is I want to put some pressure, some stretch, some engagement into that area to see if I can replicate some of those feelings in your body. But the most important thing is not that I replicate it, or not that I can feel it, that whatever my pressure is replicating in you, that it feels like it might be helpful for that problem and not hurtful. Okay, so we did some evaluation before we turned the camera on, so I kind of know what's going on in here. But But when I put my hand on a patient, the first thing I do is nothing. I don't want to provoke any sense of threat or guarding in her. Even if she's given me permission to do what I'm doing, I want to come about it in a very slow, safe way. So I'm going to slowly now put some pressure into that area. In essence, I'm looking around for things that my experience has told me are often interesting to a patient, but those findings are meaningless unless Melissa can validate them. And what are you feeling right now?
Just a little pressure and stretching.
Okay. Am I into that familiar feeling at all?
It's a little more underneath.
It's a little more underneath, so I need to come in this area, correct? Now, how about now? So, am I replicating some of that pain?
That's the area, yeah.
Yeah, is this the area where it cramps?
Yeah.
Okay. So 0 to 10, how hard am I pushing right now?
4,
Good. What number would you stop me at? What number do you think would be too much?
7 or 8.
Okay, now she said I'm at a 4, she'd stop me to 7 or 8. That doesn't mean I'm going to add more pressure. I typically ask the question when I feel like I'm in a good treatment zone. I don't use it to then either increase my pressure. Well, will use it to decrease if it's too much, but I'm at a 4. You said you'd stop me to 7. So does it feel safe? Good. Now, the most important aspect of this is, does my pressure, does my stretch, does my engagement with your ribs down in this area, does it feel like it might be helpful for that problem?
Yes.
Yeah. So Melissa immediately said, yes, it feels like it might be helpful. Everybody won't be able to answer that question. They don't know. So what I'll always do is flip the question around. If you're not sure if it feels like it might be helpful, is there anything about this that feels like it might be harmful or make your condition worse?
No, it feels very good.
Okay, good. If at any point she says, no, I don't think that's good, I'm going to immediately stop and I'm going to try something else. So what I feel certainly guides me, but I know enough about the body, about the nervous system, about the way we think we know what we're doing as therapists to know that this may never change. This lumpy, bumpy area under my hand that I used to call a fascial restriction, and you might call a trigger point or a knot or whatever, it may never change, even though we sort of trick our brains into thinking that it will. But what's important is that Melissa's symptoms change, that her ability to get up and down from supine into sitting, that changes, that she doesn't get that cramping, like right in through here. My pressure is still, but it's not concrete, meaning I'm not static and staying in just one plane. I call it sort of a dynamic stillness, a fluidity. Can you feel a bit of that? Where I'm not trying to move, I'm not rubbing or wiggling on purpose, but as maybe her nervous system adapts, as the tissue stretches, if that's what's happening, my hand is following it. We're flowing with it, and I'm simply staying with it. What am I staying here for? I'm staying here until Melissa's symptoms subside, and we reach the goals that she came into treatment for, which is so she doesn't have a cramp anymore.
You know, that video shows a lot of my model today, a lot of my model of shared decision making, hopefully building therapeutic alliance, but also the concept that I no longer try to convince them that it's a specific thing in their body. It's a specific problem that needs to melt, release, soften, whatever phrase or word that you use to describe those concepts from our training, which is a hard one for a lot of us. It's a hard one for a lot of patients. What is it that I'm looking for? What am I doing? You know, I hear that a lot in my trainings, especially from clinicians who've never taken any manual therapy training in the past, which your audience, the audience here, you know, that's your job. That's what we do, is to touch. But when I work with speech pathologists, many of them have never done any kind of touch-based intervention before, and even their sense of palpation is one that's very, very light. And when I teach them the concept of palpation and the concept of treatment, there's often a very frustrated response from them in the beginning, because it's like, if you're not saying it's the fascial restriction, if you're not saying it's the tension, if the problem isn't local in the tissue, then what are we doing? What are we trying to accomplish? What is it that's happening? And that's a very frustrating concept for them. And what I try to get across to them is anything that we feel as a change is not probably, but is an interpretation that we make on what's happening inside the body with a lot of editing based on our belief system. What I used to feel as a fascial restriction, letting go or releasing, you may feel as a not letting go or trigger point being freed up, whatever that might be. But we're doing the same thing. So as I showed in the video there, I'm not asking for any tissue to change. I'm looking for an alteration in my patient, in Melissa's experience, right? And sometimes they still want to be told, our patients still want to be told, well, what is it that's going on? I need to know. What do you think it is, Walt? And, we can handle that in a lot of different ways. But it's the experience that I'm looking to change. And that's hard. It's a hard thing to educate my patients on, that it may not be a problem in their tissue. It may simply be an abnormal holding pattern that their nervous system has latched onto. There's so many factors that go on when we touch, including some really cool concepts of interoception, which is basically our ability to self-regulate, to self-control, and create change within ourselves. That some new evidence is showing certain kinds of touch actually foster interoception, actually foster the stimulation of C-tactile afferent fibers that allow a person to begin to create change on their own, which is pretty foreign from those models that say we're making the change. And I believe if I touch my patient in a way that they feel is safe, that they feel could be helpful, then we build the possibility of them feeling safe and taking ownership and control of the process. Shared decision making is a multifaceted concept, and again, I'm going to be linking some of the evidence and the papers on shared decision making, therapeutic alliance, and some of these related concepts in the notes from this course that I really hope you take a look at. I really hope you begin to question: am I asking my patient to truly be a therapeutic partner instead of a therapeutic receiver? Traditionally, our roles are one of what's called an operator. We are the person in control, clinician as expert. Diane Jacobs and Jason Silvernail in 2011 paper compared the operator model with what they term the interactor model. In the operator model, it's how I learn myofascial release is I'm the expert. I'm basically, it's not that I'm like telling my patient what to do or not giving them input, don't get me wrong, but truly it's coming from us, the evaluative findings. It's coming from us on what we should do. And sure, we're asking questions along the way on how the pressure is, et cetera, et cetera. But for the most part, we're doing all the heavy lifting. And what Jacobs and Silvernail are proposing is to basically to balance it out a little bit, to bring elements of patient perspectives and values into this process more than people usually do, more than we've been trained to do, and in a much greater way than patients expect from us. It's hard work. It's hard work to elevate them to an equal sense of power. It's hard work for us to allow ourselves to come down to their level, if you will. And to repeat what I said earlier in this little course here that we're doing, I know a lot. I've learned a lot. I've taught a lot. I've had tens of thousands of patient clinical encounters that have framed what it is that I do. And the expectation is that I bring all of that into every session with a patient. But there are key pieces missing. The key pieces are, I don't know what my patient is feeling. I don't know what my patient is expecting, fearing, hoping for, what their values are, what kind of pressures they like, until I ask them. I see a lot on social media about the concept of the micromanaging or the controlling client or controlling patient, one who wants to call the shots and almost say, I want you to spend 5 minutes here and 5 minutes there, et cetera, et cetera. Now, there certainly are extremes that probably put up a big wall with having a successful relationship. I think they frustrate us, and they certainly frustrate the patient if we don't abide by their request or their rules, right? But to me, what some patients find as a controlling patient is, to me, the ideal patient. The patient who is strong enough to tell me what it might take to help them. Now, there's a balance, right? But can you see how the classic controlling patient, one who wants to basically say, no, more pressure, don't do that, or whatever, might simply be asking for our help in helping them? Might my frustration with that person because they won't let me do my job or what's best for them, based on my perspective, might that person be asking me to help them in a way that they would find even more effective? There's a lot of arguments, and a good friend of mine on social media just made a post about that basically don't let them dictate what we do, what you do. And I don't agree. I don't agree at all. Sure, no one person should hold all the power. Whether it's me, certainly that's my past, or them having all the power. But why is it that we have such trouble with allowing them that voice of experience in their lived experience? In the mental health field, there's a concept called priors. And when the clinician can connect with a client's or a patient's priors, then growth often happens. When we can do something in the therapeutic encounter with our patients that connects that person to the felt sense of basically why they're here seeking help, then often the outcomes can improve. The concept of priors and another concept for mental health, called synchrony. When we can take them to that place, basically where we're both in that experience of, that's that problem that I told you about. I elevate them to the point where they can actually feed that back to me and that their voice has value. There's a lot of new work that says that might be one of the most important things that I can do in a manual therapy or massage setting. Is it something that you do? Is it something that you really ask your patient to participate in? In many massage and manual therapy encounters, there's not a lot of talking going on. In fact, I was taught that I shouldn't be talking because it takes the person away from their process. There's a lot of bad baggage that I had to sort of get rid of over the years from that past model of the patient and their emotions and how it was stored in the fascia, etc. But I for the longest time, I really worked from that model of, we don't want a lot of chatter here. I still don't want a lot of chatter unless you, my patient, want a lot of chatter. But I'm pretty darn needy in my sessions in terms of asking you questions, getting feedback, making sure that what I'm doing at any moment to you feels meaningful. And that may not allow you to go into your zone that you expected to go to in a session with me. That may require you to actually be talking to me, to feeling what's going on and feeding back to me what's going on. And I do explain to people why we do that. I talk a little bit about shared decision making. I don't frame it in the way that we have here, but the concept of me not knowing what's important to them, which is why I ask so many questions. As you saw in that previous video, I'm pretty needy. And my patients sometimes get frustrated with that because it's like, well, can't you just help me? Why do you have to ask so many questions? And I keep repeating, I ask a lot of questions because I need your input in order to make sure that we're doing something that feels relevant to you and not to me. And I think that's one of the key take-homes here, is that can you envision your sessions sort of reformatted, reframed, away from that model where the patient comes in and say, I got this neck pain and blah, 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 just basically them laying back and letting you fix them. And using some of the new research on shared decision making, on therapeutic alliance, and a lot of these other related concepts that I've spoken of here, and basically having them be a participant in the session. I can tell you in my practice here in New York, occasionally a patient will stop coming or they'll fire me because I'm too much work. They'll fire me because I don't seem like I have enough knowledge because I keep asking them questions. I keep asking them what they think. But that's a rarity, especially the more I've learned to grow with this work. That's a rarity. In fact, what my patients often tell me is, I've never had a healthcare professional ask me the questions that you do and value my input so much in terms of creating this therapeutic environment. And they may not use those terms, but that's basically what they're saying, that you're asking of me things that others don't, and I appreciate that. a lot of times our patients feel like their voice doesn't matter, their opinion doesn't matter, that their feelings and expectations don't matter because they don't have the medical background that we do. And when we ask them a question, they'll say things like, well, how do I make this make sense to you? And I'll say, don't. Tell me what you're feeling. Tell me what you think. Tell me what you hope for. And the two of us together can make sense of it. Right? I think that's freeing for a lot of people because they're so used to editing. And maybe in the past someone has sort of laughed or diminished their belief or their experience in a way that made them basically say, I'm just going to shut up here because I don't want that to happen again. I try and promote an environment where a patient feels that their voice has value, that their opinion has value, that there's no such thing as a stupid question or a stupid answer. Possibly I'll come back with a lot more questions when you say things to me from a shared decision-making perspective to make sure I understand what you're saying so that we can roll that into the session. And I have basically created a practice here where I have a lot of active participating patients throughout my session. I'm fond of saying something that if my patient doesn't understand why we're doing something at any moment in the session, that I'm not doing my job properly. I don't do a lot of prep work. I'm going to give you an example. Some people will put a hot pack on a person's neck if it's a neck problem, in order to sort of prep the area, to warm up the tissues. And yeah, it's a pleasing narrative. It's a simple one, and a lot of patients really kind of believe that. They accept it, that the tissues need to be warmed up before we work, or that we have to work through the outer layers to get through the inner layers. I get asked a lot, do you use modalities in your practice wall? Do you use hot and cold? Do you use electric modalities? And I say, no, I don't. Not that I don't think they can have value, but I think the value comes from the relationship that we build, and I basically start immediately. I don't need to do prep work. Don't need to loosen the superficial. We go to the deep because I can't actually touch a deep structure. I can only touch the human being, and that's hard for some people to understand. But yet, that's why I say, if they're not understanding what I'm doing at any moment, then I need to work harder to get there. If I'm not connecting with that neck pain in a way where they say, ooh, that's it. Not only, ooh, that's it, but, ooh, that feels like it might be helpful. Or how about if you pull this way instead of going up? How about if you press harder or softer so that I don't feel like either I'm being threatened or I don't feel like you're not doing anything, right? Another favorite question of mine is, I'll ask my patient a lot during a session, does it feel like we're doing anything right now? Does it feel like we're doing anything that will be helpful for you? Does it feel like we're doing something that you thought we would do, that you're paying me for? Does it feel like we're doing something that will be helpful for this problem? Right? Those are tough questions for a lot of clinicians to ask because it requires them letting go of a lot of our ego and bringing the patient to that level that they have power, that they have important information. Once you do this for a bit, once you start building up that patient's sense of importance, I don't think you're ever going to look back. There are patients who refuse, who basically are saying, I'm going to rely on you to know. And I will accept that. I won't keep peppering them with questions constantly. I'll return a lot. I'll return a lot to make sure that I don't feel like I'm doing something that's a waste of their time and money. I won't do something that they're feeling like they have to bite on a stick to get through because they hope I will help them. But ultimately, some patients won't participate in the shared decision model. Some patients can't. My pediatric patients may seem like they can't participate to that level. My dementia patients might not be able to cognitively and communicatively participate in that way, but yet they give off nonverbal cues, they give off non-language cues that give us feedback. I worked with a patient years ago who came into me for some hip pain. And we went through our model. I was doing the MFR model way back then. This is probably close to 20 years ago. And, we did the work. We started working the psoas region, and she was laying on my table. And I said, if anything's wrong or too much, if my pressure's too much, please let me know. And she said, yeah, I will do that. So I started doing my work, my cross-handed mouth hush release work. And after a couple minutes, I looked up at her face, and she was wincing in pain. And I asked her, is this too much? And she put her hand up and she said, just don't do any more than that. I said, well, please tell me if I get to that place before I get there. And she said, okay, I will. And I went back to work, and I was doing that psoas release as I was taught. And not a really aggressive soft tissue manipulation one. It was just sort of a stretch across the inguinal region. And after a couple of minutes, I looked up again, and there she was wincing in pain again. And I said, is this too much? She said, again, don't do any more than that. And this cycle repeated itself over and over until it got to the point where I basically had to continually ask her, where's my pressure, 0 to 10? Because she wasn't telling me what I asked for. She wasn't telling me what cognitively I thought she could feed back to me. And verbally, I knew she could feed back to me. It wasn't until a couple sessions into our therapeutic relationship that she started explaining to me some of her past, her priors, if you will, that in her life as a child and an adult, that it was never safe to tell a man no. And that was a huge game changer for me. I made an assumption based on who this person appeared to be, that they could and would tell me if pressures were too much or not right. But her lived experience was one where she, even though she said she would, she couldn't. How might have shared decision making changed that? Well, I might not have, or I wouldn't have known from that first session that she was incapable of telling me stop. But now, when I work with somebody, I make an assumption that that person could have some sort of issue, if you will, that was somewhat similar to this person. And in a quiet, calm, and caring way, I keep checking in a lot more. What are you feeling right now? And I use the 0 to 10 numbers a lot, that a lot of people dislike. I'll say 0 to 10, how much force, how aggressive, how assertive does this feel? And I'll ask for a number. And then I'll say 0 to 10, what number do you think you'd stop me at? What number do you think would be too much? And they'll give me another number, right? Hopefully I'm not at their threshold or above the threshold already. And, you know, I started in the beginning just asking 0 to 10, how aggressive does this feel? And if they said, for instance, a 4, I'd say, okay, that's not much. I'd be saying to myself, they must be fine. And then I started asking that second question, 0 to 10, what number would you stop me at? And I worked at that level for a while, thinking, okay, they said they'd stop me at an 8, and they're at a 4, so they're safe. But then I realized I was still making the decision. And now I'll often ask a third or fourth or fifth question. But the third question would be, what number do you think would be most helpful? And boy, that's a tough question for some people. But for other people, it's a number that they can immediately feed back to you. I think if you went here, that would feel most helpful. And can you envision that happening? And whether you're doing dry work like my myofascial release or wet work, with lotion or oil with massage, can you begin asking your clients, your patients, these sorts of questions to give them the sense that they matter in this? That, yep, I know a lot, but I don't know what you would find most helpful. I don't know what you feel is safe. I don't know exactly what you feel will be most effective. And if you're capable and willing to help me, this partnership that we've undertaken here could even be more helpful for that problem you came in with. In a nutshell, that is my shared decision-making model. So I hope this short training might have given you some insight and information, and maybe even excited you to try some of this work. A lot of times it gets frustrating for clinicians because it seems so counterproductive from that I am an expert model. But just remember, we're not the expert in our patient's body, in their past and present. We don't know these things until we ask for their input, until we demand their input, until we let them know that they have a voice in this, and you really would appreciate and value that voice to come on. So again, in the footnotes or in the show notes from this class here, I'm going to have a lot of information in terms of papers, studies, etc. Please don't hesitate to contact me through my website, which is waltfritz.com. You can send me an email there. You can send me an email or a message on social media. I enjoy talking about this work. I enjoy getting confronted and challenged on the work that I teach and the work that I use. I don't like to make enemies in this world, but sometimes people do bristle when we challenge their beliefs. But I think it's from those challenges that we grow. So I do hope that I've challenged you today with this short workshop. Thanks for joining me. After putting together that presentation and doing an edit on it, I had a patient encounter this morning that I thought was really relevant for the content that we were talking about in the course. And patient was on my treatment table with some low back issues, leg issues, referral into her foot. I was doing my style of work, which kind of closely resembles a myofascial release type of stretching, the cross hand that's pretty common with myofascial release. And I was working on one side of her body, sort of working that QL to pelvis area. And she started to tell me about what she was feeling in the opposite foot, in the opposite leg, and the opposite back. And while she didn't say why is that, it was interesting me sort of playing back the tape from 30 years of being a manual therapist and the different stories that I would insert there as to why she's feeling it on the opposite side of her body. I was learned all sort of sayings like find the pain, look elsewhere for the cause, which was an odd thing to say. The problem's never where the pain is, which is not always true, right? Because to the patient, the problem is where pain is, and for me to say no, it's not there is negating their belief system, their lived experience. But anyway, I was just sort of internally witnessing myself going into all those old stories of why treatment on one side of the lumbar spine might have reacted and the other side. And well, there's certainly factual information there. How do we really know? How do we really know what it is and why it is? Is it good or bad? I kind of used to make those calls for patients. And I guess it's a process of maturation and evolution, where instead of inserting all these things that my patient really wasn't even asking for, she wasn't asking for explanation. She was just telling me what she was feeling, which is what I asked for. I simply turned to her and said, "Does this feel safe? Does this feel it might be effective? Is there anything about what we're doing right now that feels helpful?" And she said, "Yeah, it really does." So I was able to just sort of let go of all those old stories, let go of my need to explain, let go of my need to educate her, and allow her to drive the experience, and realizing that shared decision making does allow us and maybe require us to let go of a lot of our old stuff. Can you do it? I hope so.